Selamat pagi, Bapak Ibu. Suara saya terdengar?
Ya,
Dengar
terdengar,
Bu
Bu.
Lili.
Ya,
Dengar
terima
Bu.
kasih. Kita masih menunggu Direktur Medik dan Keperawatan Rumah Sakit Fatmawati, Bapak Ibu, untuk nanti membuka acara ini. Mohon ditunggu dengan bersabar ya. Dokter Mahen, MC sudah siap?
Sudah siap,
Oke,
Bu.
terima kasih Dokter Mahen. Sudah hadir juga ya Profesor Kinsey di sini. Selamat pagi, Bapak Direktur Medik, Dr. Taufik. Apakah sudah bergabung, Dok? Pagi, Dr. Taufik. Selamat pagi, Bapak. pagi. Dr. Taufik, sudah hadir Bapak? Sepertinya jaringan Dokter Ical, kita masih nunggu 2 menit lagi ya Dokter Ical. Bentar ya Dokter Ical. Tadi
Berapa?
sudah gabung, tapi akhirnya kok kepental lagi nih Dokter Ical.
Oh iya, iya. Oke, oke.
Oke, Dokter
Oke, selamat pagi
Ica.
Oh
Bapak.
iya, selamat
Alhamdulillah.
datang.
Ya, mungkin tadi ada
Welcome,
jaringan yang agak kurang
Pak
stabil.
Dirmed kita.
Oke. Hi, good morning everyone. Good morning, Prof.
Good morning. Shall we begin?
Kin.
Dokter,
Oke.
Bapak
Yes,
izin,
please.
kita bisa mulai Bapak?
Iya, 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 iya.
Ya, oke. Silakan Dokter Mahen.
Just a minute. Little bit problem here with the computer.
Ya, Dokter Mahen sudah bisa dimulai. Persilakan.
Ya, sebentar. Just a minute.
Ya, jaringan ya, Dokter Ical ya.
Jaringan, jaringan.
Oke, oke.
Cek. Oke.
Ya, masuk. Bisa.
Good morning, everyone. Welcome to this highly anticipated webinar on limb reconstruction perspective in managing complex orthopedic conditions. My name is Mahendra, and I am honored to be your master of ceremonies for today's event. Today, we have gathered to explore one of the most dynamic and developing fields in orthopedic surgery. Limb reconstruction is not just about restoring form and function, but it's about transforming lives. Today, we have the privilege of learning from two of the respected experts from People's Republic of China in this field, who will share their insights, experience, and the latest advancements in managing complex orthopedic conditions. Our goal today is to create an interactive and engaging learning experience, so we encourage you to stay active in the chat, ask questions, and share your thoughts throughout the session. Before we begin, let me quickly run through a few notes. The first one is about the question. Feel free to submit your question in the chat box at any time. We will address them during the dedicated Q&A segment. And then your feedback is essential to us, so please take a moment to fill out the survey. First of all, I would like to read the rundown from today's event. The first one is the committee report from Dr. Faisal. Second one is the opening remarks from our Director of Medical Service, Dr. Muhammad Taufik Azari. And then we go to the first session from our guest international lecture from Prof. Dr. Kin Sihe. And the second session is from also to our guest international lecturer, Prof. Yong Hong Zhang, and then followed by discussion, Q&A, and then closing. Without further ado, I would like to invite Dr. Faisal Miraj to report the committee report for Dr. Faisal. The time is yours.
Okay, thank you very much. Nice opening, Dr. Mahen. Good morning, everyone. First of all, I would like to send our respect to our Director of Medic, Dr. Taufik, to be able to attend this meeting, and also to all of us participants. Actually, today is very special because we have been visited by, I think, one of the big name in the field of limb reconstruction and deformity correction, Professor Qin from China, and also the Secretary General Asami, China, Professor Yong Zhang. Thank you, Prof, for visiting us. And they came. It is really an honor for us that we know that they both just held the really big event in September. We call it the Asami World Congress that been attended by 80 countries. Can you imagine? And then now we have privilege. We are lucky that they came to our hospital. This is a very honor for our hospital and also for our Asami Indonesia IDOS. Since yesterday they came, they already have seen our hospital. They have seen one surgery about the limb reconstruction, deformity correction in our operating theater, and also have already seen our outpatient clinic, and they were amazed with the cases that we usually face and what we have been performed. I think it is quite make us proud of this. And then this visit also has a purpose to make a friendship between China and Indonesia, especially in this field, in limb reconstruction and deformity, becoming grow, develop, and tighten. We can get cooperation and relationship, of course, in the way of academic. They also offer us, if there are Indonesian student, fellow, or orthopedic want to learn something from them, they will welcome. I think it is very amazing for us, I think. So in the future, the next step, we will make this collaboration more and more strong, and then we can do relation to academic by sending our fellow to their country. Okay, I think that's all from my report as a committee here, and then I will give it back to Dr. Maya.
Thank you, Dr. Faisal, for the very inspiring opening. The next agenda is the opening remarks from our Director of Medical Service, Dr. Muhammad Azari Taufik, anesthesiologist. Good morning, Doctor. Good morning,
Good morning,
Taufik.
Doctor. Yes.
The time is yours, Doctor.
Okay. Yeah, good morning, everyone. Assalamualaikum warahmatullahi wabarakatuh. I would like to welcome Professor Qin Shi and also Professor Zhang from Republic of China. We know that collaboration between Indonesia and Republic of China is really close couple years lately, especially our government has made an agreement in the medical field. I think this is our momentum to enhance our cooperation between Indonesia and China, and especially Fatmawati Hospital. And thank you so much for visiting us and share your experience in pediatric orthopedic. And for the future collaboration, I think we can make the real MOU between Fatmawati Hospital and your hospital, and what Fatmawati needs and what your hospital needs, we can collaborate each other. And then me as a director is really supporting the collaboration, the MOU and the implementing agreement between Fatmawati and your hospital. I'm really looking forward for that, especially the real collaboration, like a rare case in the pediatric orthopedy, and then we can do it together to make a better outcome for the patient. And once again, I would like to congratulation to Department of Orthopedic for make this webinar happen. I'm really proud as a director. I'm really proud of the Department of Orthopedics that really concerned about the medical services, especially for the pediatric, as we know that the pediatric is our future, our next generation. So we have to really concern about their healthy. And also our concern right now in from the Ministry of Health that children, mother healthy is our priority right now, especially for pediatrics, because pediatric kids, our kids right now, it's our future. So congratulations and thank you so much. I think that's all for these remarks. Happy webinar. Thank you.
Thank you, Dr. Taufik, for your time and very inspiring opening remarks and words. Okay, we would like to start our first session from this webinar. The first session will be the Prof. Kinsey He, and I invite the moderator for the first session is Dr. Faisal Miraj. Let me quickly read the curriculum vitae of Dr. Faisal Miraj. Dr. Faisal Miraj, orthopedic, is experienced physician specializing in pediatric orthopedics and limb reconstruction. Having graduated from the Faculty of Medicine, University of Indonesia, he continued the orthopedic and traumatology specialization in Faculty of Medicine, University of Indonesia. We've done a lot of fellowships and training. For example, the Pediatric Orthopedic Consultant Fellowships by the Indonesian Pediatric Orthopedic Society, and then the fellowship in Asan Medical Center, Ulsan University, Seoul, Korea, and Sports Medicine Fellowship in Chiang Mai, and also the Limb Lengthening and Reconstruction Fellowships, University of Istanbul, Turkey. Many symposiums, seminars, and workshops have been attended by Dr. Faisal. He currently works in the Fatmawati General Hospital as the orthopedic staff, pediatric orthopedic, and trauma reconstruction surgeon. Many professional memberships, including the Indonesian Pediatric Orthopedic Society and Indonesian Orthopedic Association. I would like to invite Dr. Faisal as the first moderator. For Dr. Faisal, the time is yours.
Yes, thank you, Dr. Mahen. Nice introduction. So this session, I will moderate this session. We have our special guest speaker, Professor Kinsey from China. He is president of ASAMI, China, and International Limb Lengthening Reconstruction Society. He's a very the most senior orthopedic surgeon in the field of the limb reconstruction. He has already managed or performed so many cases in the limb of this reconstruction. At least 40,000 cases have already been performed since 40 years ago. And all of the cases really, really well documented. So that's why we can see from those resulted in a book, a very nice book which I have been presented yesterday with the title Limb Deformity from the Professor Kinsey here. Okay, I think we can start it because we already run out of time. For the first session of the topic is about Kinsey surgical method combined with Elizabeth technique to save 56 cases of foot ankle deformity from amputation. I think for Kinsey, the time is yours.
Dr. Qin from China. I don't speak English. Dr. Qin surgical method combined with rough technique to save 56 kids with uncommon deformity from amputation. What's the fire? 不对。56 kids, 939 for 17. Average age of operation was 37 years old. Etiology of deformity. 6 kids congregate deformity of fibula and tibia only mibia. 33 cases trauma sequela. 11 cases the pain bereavement. 1 case of long limb vesicular disease. 看 by money family hospital amputation. Happy for foot and ankle deformity in 新四河 clinic. Surgical principle. Minimally invasive combined operation orthotomy, partial correction of deformity during operation. Only lay the tar of the skin incisor. Combined is rough technique collector to correct the residue there. China is rough ankle and foot. China and ankle and foot is rough. Case, man 20 year heart trauma, calf foot deformity since the age of 3 old. The patient does not agree to amputation. Look. Property X-ray. Very deformity. Short. Dr. Qin operation method. Osteotomy and enter the eardraft frame. 1, 2, 3, 4. Osteotomy. And combined eardraft. transfer the current range of external flexor. Walking. Q60D, hot sheet deformity correction. X-ray. X-ray. PO67D. Revenue. More 20. Short 9. Doctrine operation method. PO23D. PO23D. PO67D. PO150D. PO7 months. 7 months after operation. X-ray. PO7 months. Man 23 years. The patient BFID for the ankle deformity, chronic eucla. 26 year. Proper X-ray. X-ray. Horror. Operation. Left foot. Dr. Qin operation mass. The anti-leaf tendon. Tibia, posterior tibia and mu lingular tendon. Orthopedic and Irdaff technique. Length tendon. Orthopedic joint. Tremper joint. combined is rough. PO 2 weeks. The receded euclid wood was clean. After operation 28 week. With deformity correction, euclid healing. The part 28 week. After operation 110 days. After the remark of external
Hello, mana
factor,
siapa nombor? Mana?
good result of the operation. PO 2 years, deformity correction. X-ray, walking well, X-ray, ankle, foot. After operation 11 years. After operation 11 years. Operative. Post operation 11 years. Very deformity, foot deformity, severe. After left foot. Second left. Roma the from working well. PO 10 months. 1, 2, 3, 1, 2, 3, 4, 5. 4, 5. Then 23 years. For operation, walking on knee. For various foot. Corrected on by left. Surgery. Completely correct. Walking way. Surgery. Many of Paulian case is that technique, Talia, coral, Darwin evolution, interpretation, Chinese culture, natural reconstruction terror, since the natural reconstruction concept. Congenital caliper inquina. 39 years. Woman, 39 years. PO 75. X-rays. PO 5 months. PO 70 months. Second, PO 5 years and 7 months. X-ray. Reparation. Polio. X-ray. Preparation. X-ray. 30 year. Tendo antin tendolintin. Particular autotomy. Particular autotomy. Pain. Uterus. Uterus. Pain. Certainty of the operation. That 3 days. Walking. 3D X-ray. Q 3D. That 3D. Victim 15 months after operation. After operation 15 months. X-ray. Q 15. After operation, walking. After operation, walking. Per Dr. Qin operation method contained is rough U. Right. Right foot, 98 day. Right foot. Ankle. Ankle. Heart operation, 6 months. Second, left operation. 2 weeks after left operation. Left operation, past 3 months. Past operation, 2 years. 2 years. Past operation, 2 years. X-ray. Right. 5 years past operation, 5 years. Ankle. Deformity. X-ray. Ankle. PO 60 months. PO 60 is 5 years. Treatment result. 56 kids. We follow up for an average of 44 months. The foot ankle deformity were correct. Walking function of the foot was restored without screen complication. Dr. Qian's surgical method combined with ESF technique can effectively correct extreme severe foot ankle deformity. Low limb deformity is modified with by Qin's her team and published was period in 2020. Thank you. Welcome to Beijing.
Okay. Thank you. Thank you very
The
much.
first, second,
Okay. Thank you, Professor Kinsey. I think it was a very interesting presentation. We have seen a lot of complex cases about the deformity foot and ankle. I think it is one of the most difficult deformity to be managed, I think. And then, but we can see with the Professor Kinsey method, the result is very good. I think it's quite amazing. You can see from several etiology, from the congenital neuromuscular problem, trauma, all the problems can be managed with this. Okay, maybe is there any comment or question from the audience? Okay, while waiting the comment or question, maybe I would like to ask Prof. Kinsey, by looking the deformity, usually it's a chronic deformity. It must be problem with soft tissue and also the bony, especially the joint. Okay? So in your cases, we have seen there are some cases you perform osteotomy, some cases you perform also soft tissue release, and some cases you I've seen you didn't do either of that. What is your consideration of to do that? I think the option is it only soft tissue or bony or on or none of them? What is your consideration?
进去了，然后再考虑这个手术的技术和操作步骤。一次系统评价和术前设计。
Professor Qin said that before the operation we should make a thorough examination and make a complete evaluation of all the deformities and also the tendons, the tendon balance and the deformity, and make a decision before the operation. And usually we depend on if we can correct deformity, use the tendon release. If we can't, we can use the ostomy or some other methods. It is very important for the complete evaluation and make a correct decision according to the clinical experience of a surgeon.
因为我们科里面治疗了大量的至少数千例，可能世界上最复杂的足踝畸形。那么这些整个手术前的评价、治疗过程及其全程的管理，如果有感兴趣的这个同行同道，你们最好到我那儿去考察一下，看一看。单纯通过 PPT 讲解很难体现整个治疗的过程。
Professor Qin told us that he had operated more than 1,000 cases about the foot and ankle deformities. So they have a system for how to evaluation and how to make a correct the evaluation and how to manage according to the severe and according to the deformity and according to the muscle balance, and then make the operation. And after operation, they have a system of the management for the post-operative management. It is also very important for the rehabilitation and the nursing. If somebody is interested, can visit his hospital. There are so many interesting cases for you. Thank you.
Okay, thank you very much for enlightening answer. I think we just amazed with the picture, the video. So severe deformity can be have a result very good. So we have one question from the audience from Dr. Rian Baskara. How to treat wound in diabetes mellitus? Dr. Rian has asked about how to treat wound. I think is it related to the deformity or only caused by the diabetes? I think it's not too clear. Maybe, but Prof, maybe you have already also treated the condition related to the diabetes mellitus, maybe like a sarco joint. Maybe you can give us how to do management in this. Usually in sarco, there are wound, infected, and the deformity. And then also know that the condition of the bone is really osteoporotic. How do you manage it with your method using Elizabeth like this?
We have special cases, many special cases for the diabetic food.
Oh,
the later, and perhaps we can
okay.
discuss it later.
Okay, Dr. Ian, maybe you should stay until the end of this session. Maybe there will be a topic about that. Okay. Any other comment or question from audience? I assume that this one.
他刚才问这个糖尿病足，你是怎么处理的？
Okay, there is
糖尿病足怎么？
Oh yeah, there's one question from Dr. Wee.
这个
Wijianto.
等一下和他讲那个。
Dr.
一会儿就讲。
I have an adult patient with severe genu recurvatum in poliomyelitis. I want to have your suggestion to manage this problem, like recurvatum, severe recurvatum of the knee caused by poliomyelitis. Maybe you have a suggestion for Dr. Wee. Thank you.
他是说如何处理这个脊椎灰质炎，和这个什么，就是这个脊柱裂后遗症。我觉得这个题目有点太大了。
啊，这是很大的一个题目。这个可能简单的回答，你最好网上查一查我发表的文章。这个很难一个简单的能够解答。
It's really
因为脊椎灰质炎我已经做了2万多个病例了。那么脊柱裂后遗症我做了1000多个足踝畸形。最好能查一下。我发表的文章，我交给那个他的英文著作里边，已经写的比较详细了。给他说一声。
It's really to talk about it here because it's very difficult. Perhaps it's the much better way to read some books, read our books, and also perhaps we can visit us because we have so many such cases. It is very interesting.
Okay, so I think it's a little bit out of topic, but still for a deformity correction, right? But Professor suggested that it quite complex. Maybe we have. He suggests that we have Professor has a book that have already shown to us. All the cases are there, and maybe. Regarding this topic, I think maybe we can later we will answer it in another opportunity maybe. So because it is a topic about the foot and ankle maybe, and it is also a question maybe we have how many minutes more? One more question. Okay, this is from audience. In adult neglected clubfoot, there are conditions of foot adapt and typhus. Can all the deformity be corrected in a single stage? single stage. Is it possible to fix the cavus and adducts using only Ilizarov, or is a midfoot osteotomy required? Like I said, combined maybe. Additionally, should medial column lengthening with a bone graft be considered? That's I think quite long question with quite complex question. So, Doc, from the audience asked about the clubfoot, neglected one with a deformity adducted forefoot usually, and cavus. This audience asked whether it can be corrected in one single stage, with Ilizarov, or any other procedure like maybe midfoot osteotomy, or lengthening of the medial column.
OK
Yes.
OK，他说那个什么，就刚才说这个纵度马蹄足能不能一起来矫正？咱们都是一起能不一起矫正？再一个呢，就是对于他比如说前足的内收内翻的，像这种是做中度的截骨，还是做中度截骨延长，还是说做其他一些治疗，是不是一起来完成？
这个必须得个体化的评价。一定看，因为他每个人都不一样，一定根据个体化的评价和医生的吸收水平，机器Ilizarov就是这三者结合起来，所以他一定每个治疗都是个体化。
Professor Qin said that every patient should be personalized to be treated, but he always performs all these severe deformities in one stage, and after the operation, they make gradually the correction of all deformities with the Ilizarov technique. For the midfoot， 就是他中途那个，你经常做截骨吗？这些截骨延长吗？
那个很少截，这是一部分个别的病人截。
OK, only the part of the this deformities with the midfoot ostomy and make the lengthening, not all, but the only part of it, and I think 30%. Not enough, but 30% make the midfoot ostomy and make the lengthening.
部分可以矫正。
The mostly is just the ostomy of the subtalar or some triple ostomy or some other method, and also with the tendon transfer and make the correction of the severe deformity.
中度的截骨矫正，你告诉要是小切口，小切口多点截骨。
But for the midfoot deformity, with the ostomy, they only make a minimal invasive incision and make ostomy and make lengthening. Not because there's every operation is minimal invasive.
Okay, thank you, Professor Zhang. Professor Qin, for the answer. I hope it's have answered the question that being questioned by DJ. I think because we have already ran out of time, we shall proceed to the next topic. I think from the Professor Qin here, the second topic will be the topic is about Kinsey surgical method. Kinsey surgical method for correcting multi-joint deformity in lower limb. Okay, the time is yours, Professor Qin, for the second topic.
Yeah.
Perhaps it's this one.
Okay. Okay. Simple. Dr. Chin's recur method for correcting mute joint deformity in the lower limb. Complete deformity of lower limb. Dr. Chin definition. Regular lower limb, hip, knee, ankle, foot deformity, loss of upright condition in the lower limb. Multiple joint deformity in both lower limb ankle and knee by muscle paralysis. 90 joint deformity of the lower limb with combined spinal deformity. Combined tonic automated or bi-non-union bone defect. Very low limb deformity, secondary to row disease. Lower limb deformity that how thick, how surgical treatments. Dr. Chin examination, evolution, clinical, systemic, and surgical treatment. One comprehensive inspection, systematic evolution, and finding out the placement in repetition form. Two, making and treatment period. Three, optimal individual combined surgical method. For proper family equipment. 5. Let the key technical point and avoid complication. 6. Intimate treatment go and manual with patients. Dr. Chin, 1978, to find disease case, database, polio, 24,000 and 430 CP, 4,000 80 trauma sequela, 1,000. The rate code sequela, 1,000. Oral, oligate, granule, congenital triple anquineria, 784 case. EDH, 532 case. Gluteal muscle contraction, 239 cases. Quantity healthy and motor neural PC 335 cognitive multiple anthropography 161 polio 24,000 case BP trauma 1,133 case prepare CMP 335 case operation 161 with congruity fibula familiar 130 case 105 case congruity HH examination, evaluation, clinical decision making, and surgical treatment. A surgical tip and procedure without error. Part operation for pathy management and dynamic regulation. Thirdly, should avoid blood transfusion and much as possible. Part operation follow-up time 2 years. Case Miller 27 year failure 5 deformity of left lower limb hyperfixation and abduction external rotation knee flexion and polio period simulation surgical correction is retrieved for operation for doctoring operation method clip femur autotomy femur autotomy femur autotomy correct parvo intra external function plate combination surgery and intra and external flexion for correction of low limb competent deformity. PO 31D PU31D removed the external fixing and asymbol knee joint breathe to activity walking. PU31D. Second case, 25 years. Factor operation, right firm, fibula and fibula, multi-point osteotomy, erection, coral. Ducting operation, right femur, volute osteotomy with internal flexion, fibula osteotomy, fibula, femoral, right, fibula osteotomy, fibula, the fibula, and is the external flexion. PO30D, correction of right curve 40 X-ray of low limb titanium. PO40D, right limb, X-ray, film, excellent table, ample osteotomy, low osteotomy. PO, right limb, 100D. The same surgical method is used to the left side after 5 months. Deleted low limb deformity corrected. After 5 months. X-ray, femur, tibia. Walking in the sister and brother both left from the lens. Sister, brother, both. PO 35 months. X-ray. X-ray. 10 osteotomy after first operation 35 months. BCH 18 years. 12 injuries and internal return deformity. PO 6 years, 70 months, completed recovery of long limb, axis under joint limb. PO 70 months. X-ray. Walking. Polio, 19 years, paralysis of the right lower limb with fixing of the knee, external retraction of the lower leg, and club foot deformity. Foot, ankle, knee. Operation. Dr. Qin operation. Film. People. Entry. Dr. Qin surgical. Can do this. Osteotomy of female upper tibia, soft to correct knee flexion and curve external. Region deformity, short plate and long external flexor, cross knee flexion, combined foot and ankle. Limit deformity 3 with rough concrete external flexion. When it's rough. PO 7D X-ray. PO 3 months. The X of the thighs remain and breathe and setting, breathe, firm breathe. PO 120D. Remain external flexion of calf and ankle. PO 150D. Look. Breathe. PO 130D. Walking exercise with long leg. Breathe. PO 43 months before year. Deformity of the right long limb was corrected. The teeth factory. Rectory. The teeth factory walking function. Knee bowing without obstruction. Knee function. Walking. Femur. Knee. Ankle. Foot. case. Congenital bilateral patellar dislocation with knee fixed deformity. Very knee deformity. Seventeen years. Keep dislocation. Hitler dislocation. Dr. Qin faster surgical treatment. What right limb, left limb, left congenital heart operation 21 months. Heart operation 47 months. PO 37 months. Walking. X-ray, femur, hip. Case. Women. 14 years. Congenital tibial arm deformity of right side fibula. The fibula, the tibula. Heart surgery. 5 years. Pro heart operation. 5 years. Heart operation 5 years. Pro walking. Pro watching 14 years. Heart operation 20 PO 2 months. Second operation. Third operation. Fourth operation. PO 26, PO 4 years. PO 5 years. In the family radio. There are many methods you can know to western Dr. Jin clinical principle, surgical method, and evolution criteria for treating difficult and complication disease. Welcome to Dr. from all of the world to Beijing. Dr. Orthopedics Department for Investigation, Exchange, and Further Study. Doctor and patient is a friend. Those who create history. Thank you very much.
Thank you very much. I think I cannot say a word. I think it's just amazing. I think regarding you see the previous before the surgery and then after that, all the complex deformity that I can imagine. I think how to manage it, and with the processing method, I think it is really amazing. Okay. For the audience, maybe you have a comment or a question after looking. So the Professor Chin have really a lot of cases, almost 40,000 cases for about 40 years, and it is. I don't think I can imagine how Project Kin can make a database such well documented. Even though nowadays in our hospital, maybe our hospital, it is hard to get the patient's data, but Project Kin can do it since 40 years. Is there any question or comment maybe from the? So,
Do you question?
yes. Okay, maybe I will ask Professor Chin. Okay, the problem usually we face in this kind of patient, usually complex deformity, it is how to make the patient can like your slide last slide can cooperate with us, because it must be a long time period using the Elizarov sometimes, and then all the complication such as pin track, stiffness, and also sometimes patient would stop from the management. And how would your approach to the patient in China to overcome this problem?
因为我那个科室和团队啊，病人比较集中，这样术后的管理呢，它不完全是一个技术问题，必须有一个医患对认可、互信，而且病房里边都有一个文化的环境啊，所以搞这个专业搞得好，这个病房的文化环境很重要。所以如何在一个病房设计里边创造那么一个让病人能够高兴、乐意配合这么一个文化的我们叫气场，或者怎么翻译，对这个复杂的畸形的治疗有些重要。因为我那里那么多患者，可能基本上是没有碰到就中间放弃治疗啊这种病例。
So, oh. Okay.
Okay, I'm so sorry, but Professor Chin said that confidence is very important. Before the operation, we should the patient and doctors should be have the confidence with each other, because his orthopedics is quite famous, and the patients from the old countries to come to him, and there will be a confidence between each other, and the operation and all the patients have the thorough follow-up with his doctors. So that is they have the have a contact frequently. So when they have any problems, they contact with the doctors immediately. So this is the mutual confidence. So until now, they have no patient that lost follow-up. And for the pediatric infection, and also for the stiffness, for these all problems, they come to him, or they solve this problem immediately when it happens, and also the rehabilitation is done properly.
Okay, thank you. Really enlightening answer. So we have one question from audience now, from Vivaldi. Can every deformity be reconstructed, or are there certain assessment in carrying out reconstruction?
Okay. 就是是不是所有的畸形都可以矫正？是不是所有的畸形都可以矫正？或者是说，有一个特定的这个评价标准来执行重建？
因为我那个科室里边都设计了很多表格，评价表格，这个至少设计了有10几个评价表格，根据不同的病症。凡是能够治疗的，必须通过这个评价表格，这个去随后的检查评价，并不是所有的畸形都能矫正。可以说还有相当一部分患者，你看医生的能力，患者的接受程度，以及呢患者的全身状况、年龄等等，其中这边还有相当一部分患者是不建议做手术。
Thanks for your question. And Professor Qin said that first question is not all the deformities could be reconstructed until now. And they have the more than dozen evaluation forms for the patient. And every deformity patient should be accessed with these evaluation forms, and which is the best way for the correction, for the reconstruction. When it is better for the patient to with correction or reconstruction, they perform operation. Otherwise, they are not be operated.
因为我的科室呢，还有一个比较特殊的地方，有全国各大医院不愿意治疗的这些复杂的下肢畸形，有相当一部分都介绍到我那里去，所以这样就逼迫着我这个科室呢，也必须想方设法的，尤其是青少年的严重的复杂畸形，尽可能采用包织手术的成败。所以我的科里边不做截肢手术，如果需要截肢的病人，我也会转到别的医院去。
In China, there are so many severe deformities in China, and all the deformities, many deformities that was treated by the many university hospitals that they can't be treated in these hospitals. They always transported to Professor Qin's hospital, and so he always tried his best to treat all the patients. That's why he has so many very difficult cases and critical cases for the treatment. This is why, and he had so many cases, so many experience in this area.
Yes, okay, thank you, Professor Chin. I think the message is we have to know exactly the problem of the deformity. All the problems should be assessed and then consider the best way to solve that problem. I think it is actually really advanced limb reconstruction. Maybe we have, like the Professor Chin offer, maybe if anybody want to go to China, visiting him, and learn from him. It is open, welcome. Okay, once again, I think this is the end of our session, the first discussion with Professor Chin. Thank you, Professor Chin, for the sharing of amazing experience. And if you guys want to know in advance, you can find it in his book, The Lower Limb Deformity, that have already shown previously. Thank you very much for your attention. We go back to the MC. Thank you.
Thank you, Dr. Faisal, and thank you, Prof. Kinsihe, for the very amazing and insightful thought and experience. After this, we will go to the second session from Prof. Yong Hong Zhang. First of all, I would like to invite Dr. Asep Santoso. Let me read the curriculum vitae first. Dr. Asep Santoso is graduated from the University of 11 Maret University in Solo, and then he done the fellowship and subspecialty in clinical and research fellowship in joint reconstruction surgery from the Gwangju City, South Korea, and then the adult reconstruction fellowship from the Indonesian College of Orthopedic and Traumatology Hip and Knee Society, and then also the Asia Pacific Orthopedic Association Pune course in the traveling fellowship in Pune, India. Currently, he is in the division of the adult reconstructive surgery and sports injury, Prof. Soeharto Orthopedic Hospital in Surakarta, and also in the committee of the APOA, Asia Pacific Orthopedic Association, and the Scientific Committee of Indonesian Hip and Knee Society. Uh, okay, let me welcome Dr. Asep. Good morning, Dr. Asep.
Good morning,
Good
Dr.
morning, Dr.
Mahen.
Thank
Is
you,
my
Doctor.
voice clear?
Yes, clear, Doctor. I
Okay.
would like to, the time is, Doctor, thank you.
Yeah. Okay. Thank you, Dr. Mahen, for the kind introduction. So we will proceed to the second session. We have here Professor Yong Hong Zhang. Good morning, Professor Zhang.
Good morning.
Good morning. Very nice to meet you. Let me explain about Professor Zhang. Professor Zhang is from the Department of Limb Reconstruction at the Second Hospital of Shanxi Medical University, Republic of China. He is currently the chairman of Chinese Bone Transport and Diabetic Foot Society, Secretary General of the ASAMI China and International LLRS China. Also the chairman of Shanxi Medical Doctor Association for external fixation and limb reconstruction. He have so many experience about this field. Professor Zhang will present two lecture. The first will be about Elizarov technique for the treatment of severe post-traumatic problem. And the second is about the preliminary study of tibia transport, bone transport for treating severe diabetic foot. So Professor Zhang, this is your time to present your first lecture about Elizarov for post-traumatic problem for 20 minutes. Please, Professor Zhang.
Thank you. Thank you for moderator and for the introduction of my curriculum variety and I want to share my moment. This is the could you tell me on how to share my yeah. Yeah, I don't know exactly. Oh yeah. Oh, okay. Oh.
Mohon izin Dr. Asep, little problem with the,
Ya.
because dia pakai laptop sendiri.
Oh ya ya. Sepertinya terlempar dari Zoom ya beliau.
Iya, makanya.
Oke. Ya. You already in again, Professor Zhang. We can see your PPT here.
Okay, it's good.
Yeah, it's good.
Okay. Okay, thanks, moderator, and I'm beginning my presentation. Thanks for having me here for sharing my experience of my work, and my topic is about the distracting heterogenesis for treatment of severe post-trauma sequela. Of course, we know, or everybody know this technique. We don't we say nothing about it. And this is our cases, and we can now I introduce some of our cases here. And this is the chronic tibial osteomyelitis with dislocation of the upper and lower tibial fibular joint after severe trauma. This is the case. And this, the red picture is the just after the injury. He is 17 years old, was into the hospital 12 hours after the traffic accident. He has a hemorrhagic shock and stripped skin of the right leg and mass contusion of his right leg, rupture his right artery tibialis anterior, and a comminuted fracture of his right tibia, location of his right upper and lower tibial fibular joint. For the patient, when we perform the operation, we pull the fibula, but it can remove from the tibia very easily. So all the tendons will be damaged. And there's also the fracture of calcaneus and the contusion of his right common peroneal nerve. This is X-ray. We can see the inferior tibial fibula and the upper tibial fibula dislocated. And he has a skin transplantation for twice, and the 70 days after the management, he come to me, and this is his skin. We can see there's the bone exposed with the pus. And the 7 days after the emergency management, we can see that the dislocation here, 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 and also the after 70 days with the autoparesis. For the treatment, we make the radical debridement, reduction of the upper and lower tibial fibular joints, and application of the circular external fixator. This is during the operation. We and just after operation, we make the otomy for the bone transport, and for the lower part after reduction, we try to use the oliver wear to fix the deformity, fix the dislocation. But because the severe osteoporosis, the oliver was in the inside the bone, because you can use a wear easily with hand thrust into it. The 12 days after operation, we make the bone transport, and the velocity is the two-thirds and the millimeter per day. And the 38 days after operation, we can see it's very painful. And the upper tibial fibular joint was kept reduced, but the lower tibial fibular joint was dislocated at the 35 days after the operation. And 83 days after operation, that's bone transport. And 132 days after the operation, and And during this period, and many professors joined the discussion of these cases. Everybody suggested to make an amputation for these cases because they believe this because the tibiofibular ligament was damaged, so they suggested to make amputation. They suggested that there's no possibility for this patient to walk. And these days we make the 141 days make the reduction of the lower tibiofibular joint, and with a bolt and washer to fix it. And also because there's a club foot of his ankle, and so we add the ankle hinge configuration for the correction of the equina deformity. 146 days after operation, we can see bone transfer is bad, and also nearly docking. And 146 days after operation, we can see the skin is much better. During at the 189 days is the docking side is nearly healing. The skin, and he can use one crank walking. And the 230 days of operation, and we see everything is good, and the autopoiesis is much better, and the patient can walk gently. Okay, and after 10 months, the chronic osteomyelitis was cured, and bone defect was repaired by bone transport, and the upper and lower tibiofibular joint was recovered to the normal relationship. The skin of his right leg was recovered. His equine deformity was affected. Blood supply of his right leg was recovered, and her right common peroneal nerve was recovered, and the bone density of his tibia was greatly improved. This is, and we removed the frame, and this is the 485 days after operation. During the follow-up, we can see the skin. As the X-ray, we can see it's good, and we can see his function is good because of time, and we didn't see the such one. And this is 3 years follow-up. And this 8 years follow-up. Because he liked jogging and the mountain climbing and everything. This is the daily life from chat. He sent it to me, and he always show his hiking, mountain climbing, and something else. It's all his story. And another case is the chronic humeral osteomyelitis with complete injury of his right branchial plexus trauma. It is a root injury, and it is 26 years because the sustained injury to the blood vessels, nerves, and tendons, and after corn harvester injury, and underwent multiple debridement with flap transplantation, after injury. But later, he had developed a redness, swelling, and sinus formation in the middle of his lateral right upper arm. 15 years later, he suddenly experienced pain in his right upper arm, and accompanied by limited movement, and X-ray shows fracture and pathological fracture. And when we make the examination, it's significantly muscle dysfunction in the right upper limb, and there's loss of temperature and pain sensation on his right upper limb. The bacterial culture result is infection of the Pseudomonas aeruginosa and Klebsiella pneumonia. And 6 months post-operatively after the injury, with the osteomyelitis and the plexus nerve injury from the root. This amendment, we make the sorrow department and the external fixator for the bone transport. During operation, there's so many parts around the nerve and the blood vessels and around the muscles. So this is the observation. We use the antibiotic embedded bone cement. And the 34 days observation follow-up, you can see it's okay. And 58 days observation, we underwent a bone cement removal and debridement and draining tube investigation. This time, and we make the culture is the Acinetobacter baumannii infection. And the 75 days after first operation, we must make another debridement, also the antibiotic calcium sulfate filling, and also for the bone transport. And bone defect is 5.5 centimeter. And this is the process. And 136 days bone transport. We can see the bone transport is nearly finished. And we make a reverse bone transport. It is the according technique. And then we back. This is the process. And this is the follow result. We can see the X-ray is not straight, but it's good. It healed, and but to our surprise, the nerve recovered. Part of the curve, the nerve function recovered. We can see the function. You see taking the function of his for the dorsiflexion is coming down. Okay. We can now another cases, and it's a 56 years old lady has a history of the lower leg trauma, which gradually led to deformity, allowing her walk with crutch. years ago, he fell again and injured his right lower leg, resulting in a right tibial fibular fracture. But he didn't treat. So he managed conservatively at home. This patient diagnosis is a non-union of the right tibial fibular fracture and right knee varus deformity, angular and varus deformity of the right tibia, and type 2 diabetes, poor controlled blood sugar. He had suffered the coma because of the diabetes. This is the clinical photos before the operation. You can see the deformity, and there's a deformity in the knee, and also there's a non-union here, and with the deformity at the lower part of the tibia. You can see the deformity also here. We can see deformity here and here, and with non-union. And our plan is that mix the otomy at the upper side above the tibial tubercle. Also with the external ring external fixator. This is the operation, and just apply external fixator, and of course we should mix the otomy of the fibula, and also the otomy at the proximal tibia. This is the otomy and tibia, and the mix also the fibular ostomy. And after operation, we correct the deformity of the upper tibia gradually. But for the non-union of the tibia with the stable fixation, also with the distraction here, it will heal very quickly. We can see here healed, and the deformity corrected. Because his poor condition, so we didn't perform the otomy here simultaneously. We perform it later. This is 63 days. We can see the deformity is corrected because the patient has the poor condition with the diabetes, also with the coma. So we the next operation was performed a little bit later. And 168 days, we performed the second operation for the otomy of the lower part of the tibia. And after correction, all the deformity corrected. And the 197 days, it calcified very good, and it's with much more callus. And this is the bone, and this is the function. And another case is a 26-year-old male. When he was 7 years old, he suffered severe trauma of his right leg.
Professor Zhang, I'm sorry, your time is 3 minutes left. 3 minutes left.
3 minutes left. Okay.
Yes.
Just show you this picture. Show these cases. You can see the pictures. This is the clinical view. You can see because it has so many deformities. We also with the ankle. The treatment plan. First, we make otomy supramalleolar and make the lengthening, and then we then correct the deformities because he has the nerve function. Have posterior tibial nerve is the tibial nerve is completely injured during childhood, and so he when he press someone, he can suffer a compression necrosis. But after this treatment, all deformity corrected. Also, there's no blood supply below the ankles. We can see this is quite good. Because he has a hard callus, so he come to me for this problem, but he can work very good, and he return to his normal work and normal life. Because the time we finish it, this is another for bone non-union. We have developed technique for this delay union or non-union. Okay, this is the all the advantage of distraction histogenesis. I think everybody will know, and I didn't say it again. This is our group. Thanks for everybody, and thanks for having me here.
Yeah.
Okay.
Thank you very much, Professor Zhang, for the wonderful presentation and wonderful cases. I believe that you have more cases, more severe cases. Yeah, but because of time, I think we have already gathered some question. Maybe I will start from me about the question. Maybe you have a lot of post-traumatic cases, Professor Zhang, that we see sometimes the case, like in the first case, you show that the case is combination of the bone problem and also severe soft tissue problem. In your case, the case Elizarov is not put at the first moment. What do you think if the case come to you? Do you prefer to put the Elizarov frame from the beginning, from the first surgery, or no?
Because thanks for your wonderful question. But because of the I received this patient 70 days after the operation. From the emergency, from injury, after 70 days, he come to me and apply the frame. But at the beginning, they are in the local hospitals, not in our hospitals. This is one reason. But I'm not suggested to use the ring frame at the emergency room because they need time for the young doctor. It's very difficult for them. During the emergency time, time is very important for saving his life because he has a hemorrhagic shock and have so many problems, skin problems. So it is very important to try to save his life.
Okay, so you prefer not to put the Elizarov frame at the first surgery in the emergency room. Okay, thank you, Professor Zhang. Okay, another question regarding the bone transport, especially for lower extremity. We see your case, bone transport of the tibia for the first case. What I want to know is what is your protocol of weight bearing for the patient who receive bone transport? Do you allow patient to directly weight bearing or wait until there is some docking side contact to allow patient to weight bearing?
Thanks for your wonderful question. It is very good for every cases. It is very important for this patient. All our patients are rehabilitated immediately after the operation. if it is not severe osteoporosis, we usually ask them to stand after operation. When there's no bleeding, encourage them to walk, sometimes to climbing or something else. But for the severe osteoporosis, we should make the rehabilitation to improve his osteoporosis. And when the bone density is improved, and they gradually they walk. And first, it can use a crunch, and later and gradually remove it. And it's very important for all cases. Nearly all my patients work at operation with crunch at the beginning and later without crunch.
Okay, so you allow your patient to early weight bearing.
Yes,
Yeah,
exactly.
yeah. Even though there is still some bone gap during bone transport, you allow patient to walk. Okay.
Yes.
Yes. Okay. Thank you,
Yes,
Professor
yes. So
Zhang.
even with the gap, I always ask them because I always make a stable fixation, use more pin or wear. I think it's stable enough for the patient to walk without crutch.
Okay. Wonderful. Thank you, Professor Zhang. We may see,
You're
is there
welcome.
any question from the audience? We have no question. Maybe again, question from me. We see in your second case, you put bone cement first in the gap before you start to do bone transport. What do you think about what if we just directly perform bone transport? We do not need to wait for the infection. So what makes you choose to put bone cement first before bone transport in your second case of humerus?
Yes, because it's the bacteria is the bone marrow. It is a very critical bacteria, and it is listed in the WHO as the critical condition because it's not sensitive to the antibiotics. So we usually for this patient for this bacteria we usually first we use the antibiotic embedded bone cement, and later we make the bone transport because we are afraid of they are not the infection can't be controlled after the bone transport.
Okay, so because the infection quite severe.
Yeah.
Yeah. So I think it's depend on the type of bacteria also. Okay, so in the second case, also it is interesting if we see that you did an accordion maneuver to improve the callus formation. Can you explain to us, or you can you share to us your experience on what is your indication to decide to do accordion maneuver during your destruction histogenesis procedure, Professor Zhang?
For this patient, the second case is because it's first he didn't want to make the amputation because it's he's complete the the bronchial plexus injury from the root.
Yeah.
Yes, and so at the beginning, and also with the pathological fracture, and the many doctors suggested to make an amputation for the cases. And we just want to try if our bone transport is benefit for his with his nerve, because we have so many cases that after the bone transport the nerve function recovered. So this is the case why we treated, but not all the functions of the plexus, brachial plexus recovered. And
Yeah.
something.
Yes, I think my question is about accordion maneuver, Professor Zhang.
Accounting technique.
Accordion.
Okay.
Accordion maneuver.
Accordion
Sorry,
maneuver.
I'm
Okay,
sorry.
I'm sorry about
Yes,
it.
accordion
The
maneuver.
accordion
I'm sorry.
maneuver is that yes, accordion maneuver, and we find that not every cases use accordion maneuver is successful. Only when there's the hematoma and the bone defect, can be treated with accordion technique. You can see this picture, and this is our
Yes.
protocols for the accordion technique. And when there's hematoma and the blood flow was observed by ultrasound, then we can use the accordion technique. If there's no hematoma, we must perform the focus shockwave therapy at the docking site or the non-union site, and then we perform the accordion technique. This is very important for successful accordion technique.
Very interesting. So you combine the accordion maneuver with evaluation by ultrasound.
Yeah.
Ultrasonography to check the blood flow. Very, very interesting. Thank you, Professor Zhang, for your insight. I think we still have some question. Oh, no question from the audience. Maybe the last question for this session is we see that many cases of you performing Elizarov with transarticular frame, Professor Zhang. But we see also that the final result, like your case, the first case, after 3 years, the patient regained full knee flexion. Do you have any special tips or special procedure perform to the joint to prevent the stiffness or to overcome the stiffness of the joint, especially the knee joint?
For you mean the knee joint for the first case?
Yes, knee
Yes,
joint.
it's quite good because of his after operation, and he always makes rehabilitation, and he moved his knee and also the ankle joint. But the ankle joint, because as you know, and there's severe damagement of his ligament. This is a problem that for his ankle joint to recover, but for the knee, this is no problem because he the frame doesn't give him the obstruction for his knee movements. That's why he can have a good function of his knee joint.
Okay, so no specific surgery for the knee joint for your first case.
No, currently no.
Okay, excellent. Thank you, Professor Zhang. So I think the time is up for the first lecture. Thank you very much, Professor Zhang, for your wonderful lecture and insight and sharing your interesting cases. We may close our first lecture, and now you can proceed to your second lecture. Please, Professor Zhang, time is yours.
Thank you. Okay, can we begin now?
Yes, please, Professor Zhang,
It's
please.
okay. Okay,
Yes, yeah,
now
you can
it
begin
can
now.
work now. Okay. Another topic is about the reconstruction in severe diabetic with severe bone transport. Now there's audience that interested in the diabetic food, also with interested with the wound for the patient with diabetic food. Now we are talk about this topic. Of course, everybody know what is diabetic foot. It's mainly reason is neurovascular disease and also the vascular disease. It's because of the macro circulation, also the peripheral nerve. For the peripheral nerve neuropathy, it's the main and basic etiologic factors of diabetic foot. It has the greatest impact on the pathological change of diabetic foot. Also, sensory disturbance lead to the loss of the sensory protection. Also, the autonomic nerve dysfunction lead to the skin gland dysfunction and dry skin. For the macrocirculation, also is the very important factors for the diabetic foot. We can see for the treatment, we can treat the diabetes mellitus with insulin or some drugs, and also with the diabetic foot care, and we can management of the infection, and also we can management of the detectable bone blood vessels. But we don't have the way for the improving the peripheral nerves, and also in no literature report on the improving the macrocirculation. That's why we use the bone transport. Of course, it is from the Izarov. Everybody knows the USSR, the discovery 315. This is the tension stress law. This picture is from the Kurgan, and we can see after bone transplant, there's a large amount of blood macrocirculations reconstructed. Okay, we can we can see some cases. This is the 58-year-old male, diabetes for 6 years, and the numbness and coldness in both lower limb, and the repeated rupture for 6 months. And for the treatment, there's no good result, and always recurrence. Always here, repeated rupture here. And but we use this frame for the tibia transverse bone transport. Only 2 days after bone transport, as we can see, the redness is relieved. And 5 days after bone transport, the inflammatory reaction subsided, and patients feel partly the relief. And 10 days transport, the wound healed smoothly. Because we treat so many diabetic foot with this way easily and without any difficulty. So we meet the problem. This is the 47-year-old male, and the left foot ulcer and blacking with gangrene, stink for 4 months, and diagnosed as diabetes mellitus 2 in 2015. Bad control, smoking, cigarette, alcohol. This is his bacteria, it's Proteus mirabilis. This bacteria is the world, and everywhere can smell this terrible stink. As X-ray, we can see the bone was damaged by the bacteria. This is angiography and the bone transport, because we didn't find there was the abscess just below the medial malleolus. We just remove the gangrene and make a small debridement, because we think our method can eliminate all the infection. But in fact, this 33 the effect continues. So he was debrided in another hospital, and we also with the bone cement implanting. And 77 days after first surgery, we can see it's much better. And 120 days, we remove the bone cement and leave a huge wound. And we can see it healed very quickly. And we can see the first picture, it is 120 days. And the second is 127 days, just 1 week after the treatment. And we can see it is huge, and here it is so small. And the wound healed from the both sides. It is it's more than 1 centimeter. Can you believe? For a young baby, it is possible. But for this 47-year-old diabetic foot, it healed so quickly. And he recovered his normal life. This is the during his follow-up, his food and his work. Another case is the 65-year-old male up to diabetes mellitus for more than 20 years, gangrene, and also diabetic eye disease and chronic cerebral infarction for more than 10 years. And also there's a support glyceria control. And also he suffered hemorrhagic coma. And also he's smoking, drinking. This is his food. And what's your strategy? And many doctors told me that must be amputated. This is X-ray. It is the damage of the bone, and this is the angiography. But we perform the transverse bone transport. We use the bone cement, antibiotic embedded, and also with the drainage. This is 22 days, 43 days, 50 days, and 64 days. And it's 99 days. And it's 118 days. And it's 146 days. And 2 weeks later, after this follow-up, and so we asked him to come back. And he told me that he has completely recovered. He wasn't willing to come to me now. Another case is it's a 60 years old male type 2 the diabetic foot for 10 years, smoking, alcohol, diabetic foot for 1 year, and diabetic neuropathy, and diabetic retinopathy. This is angiography, and we can see the back of his foot is nearly no soft tissues. This is, and then we use the bone transport, and we can see this is his wound, and we can see his wound gradually reduced, and 48 weeks, and we can see nearly small. And some other cases you can see, because time, and we do it quickly. Okay. From our basic research and some other research, we can say transverse bone transport by histogenesis activated vascular nerve regeneration associated factors expression. The collateral circulation, macrovascular peripheral nerves improve and enhanced tissue repair capability, and significantly enhanced resistance to the infection. That is a take-home message. Transverse bone transport can be an effective method for severe diabetic foot. This is some of the scenery of our province. The left side is more than 1,000 years. This is in our city. This is on the cliff. This temple is completely on the cliff. It is very beautiful. And this is from a temple. It's small, but it's very beautiful. This also is more than 1,000 years also. This is the Yellow River, and this is the biggest Buddha in China. This is the cliff. We can see inside there's no GPS. This is the old city in our province. This is our group. Thank you very much.
Thank you very much, Professor Zhang, for your wonderful presentation. I think this is a very interesting concept in managing the diabetic foot. You have a lot of good experience and good case to share with us. So maybe some question about. So I understand now that the concept of bone transport is to increase the microvascularization, yeah, for the lower limb. So my question is about more technical maybe. I think we don't have question from the audience. So what is the length of the bone that you cut on the tibia and the thickness of the tibia that you do for transverse bone transport?
Okay. I'm sorry about it, that not because it's quite easy. We use a minimal invasive automated tool to do it. Just from the lateral side, make a small incision, just 1 centimeter, just like here. We make the incision, and then we import this minimal invasive automated tool, and just like a stamp hole, and make just like this one, and make the automy, and then we use this simple frame, make the extraction of this bone block. And 7 days or 9 days of the operation, we make the distraction until the skin tense is intense, and then stop, and then 7 days later, we gradually make the reduction of the this bone segment, bone block. Is it clear? I don't know.
Yes. Okay, it's quite clear. But I want to know also how long you will usually you remove the fixator, the frame. How long you will remove
Yes, and
yeah.
The good question is we usually remove frame after the bone healing, because it's bone transport. It is just like the according technique. The bone healing is very quickly. So after the reduction of the bone block, and it healed very quickly, and when we see the obvious the callus between the bone block and the tibia main block, and then we remove the frame.
So you wait for the bone to heal again. Yeah. Okay.
Healing.
Thank you,
Waiting for healing.
Professor Zhang. We have some question from the audience here, from Dr. Rivaldi. In the cases of diabetic wounds, is it more important to control the glucose level or treat the diabetic wound with bone transport? Both need to be done in the healing process. So I think the question is about is it important to control the blood glucose first, or you can simultaneously performing transverse bone transport in the case of diabetic wounds?
Sorry for the
Sorry, the question is you do both controlling the blood glucose, or you wait to the blood glucose normal first and then you perform bone transport. So you do in both.
Yes.
Or you just wait to blood glucose control first to do bone transport.
Yes, and we usually waiting for 7 to 9 days for the bone transport. Not immediately.
Okay, so not immediately. You control the blood glucose first.
Blood glucose is blood glucose is before operation. We control the blood glucose, but not strictly. Usually, we allow to the blood glucose less than 9. Usually, we before operation, we usually control it before with less than 7. But for the diabetic food, we can allow the less than 9 for the before eating, and it is allowed to less than 9. And
Yeah.
for the 2 hours after lunch, after eating, and it can be less than 11.
Thank you, Professor Zhang. We have one other question from the audience.
Mhm.
What do you think? What is your opinion about the use of Ilizarov technique for arthrodesis of the Charcot ankle? Professor Zhang, do you have some
Yes.
experience for arthrodesis of the Charcot ankle joint?
Yeah, for the
Yeah.
Charcot patient,
Yeah.
it's very difficult because it's easy to lose the the stability of the midfoot. It makes the foot become the deformed. So it is very important to make a stable fixation of the midfoot until it is completely healed. This is very important. This patient, for the wound, its method is also work, but you should pay more attention that the bone structure don't be destroyed.
Yeah, because arthrodesis in the Charcot ankle joint is sometimes end up with failure and non-union.
Yes, and so
Yeah,
it is the
yeah,
problem
yeah.
is we make it stable, and so until it is healed. And the last time, Dr. Zonetting from the Kukan also talked to me and about it, and that it's very very crucial for the management of these cases. And so he suggested we use he also used some special method. For example, they use how to say it is some field therapy for these cases to increase the healing of the midfoot.
Yeah. Okay. Thank you very much, Professor Zhang. I think because the time limitation, it is very happy to have you here to discuss about your expertise in the use of the Ilizarov frame for post-traumatic case and also for the diabetic foot problem. So again, thank you very much, Professor Zhang, for
You
your
also,
insight and on sharing your experience. I think we can finish or end up the second session and give the time back to Mr. To the Master of Ceremony, Dr. Mohan. Thank you very much. Thank you, Professor Zhang.
thank you. It's my pleasure. Thank you very much.
Waktu saya kembalikan kepada Dr. Mohan. Maaf, Dr. Mahen, apakah ada di tempat? Ya, terima kasih.
Dear participants, as we come to an end to the engaging section of film reconstruction, managing complex orthopedic conditions, I would take a moment to reflect the knowledge that we've gained today. We explore any new techniques and then perspective and gain practical insights in managing complex orthopedic cases. On behalf of the organization, I would like to express our sincere gratitude to our distinguished speakers, Prof. Kim Suhe and Prof. Yang Hongzai, also the moderator, Dr. Faisal and Dr. for generously sharing their time, experience, and expertise. A big thank you also to all of the participants for your active engagement and thoughtful questions.
Once again, thank you for attending and being part of this webinar. We hope you leave with the new knowledge, perspective for work in limb reconstruction. Take care and have a great day.
Thank you.
Thank
Bye-bye.
you.
Thank you, Reza.